Good evening, all. It's really a great pleasure to attend this meeting and also to introduce Dr. Balamurugan Rathinavelu. He's a close friend of mine. We work together in Mafraq Hospital in Abu Dhabi. I'm really happy that we could get him on to speak today. He's a very popular radiologist, very dynamic and also very active in all the academic activities. He has done his FRCR and a board certified member from the UK. Presently is the consultant radiologist from Sheikh Shakhbout Medical City. It's one of the bigger hospital and a new hospital also in Abu Dhabi. It's also partnered with Mayo Clinic, so they have a lot of guidelines from USA. Dr. Bala is the lead radiologist in surgical and trauma, and he regularly attends the clinical conferences regarding especially with surgical and trauma and related to abdomen. He's associate professor from Khalifa Medical University of Abu Dhabi. He has many achievements. He has more than 24 posters and presentations, and more than 9 publications, more than 15 auditing data. He is the chairman of editorial board of Coma Journal. He received a clinical excellent award. He is also a research lead in Chesterfield Hospital in UK. He is also lead in the audit and also discrepancy meetings. He is a member of many organizations, radiology organizations like Royal College of Radiologists, European Society of Radiology, British Society of Interventional Radiology. He is a member of ESGAR and also British Society of Gastrointestinal and Abdominal Radiology. He is my personal friend and he used to really help me in most of the times in the department with the difficult cases. I still follow his MR angiography protocols. Over to Dr. Bala.
Thank
Bala,
you.
You are now the host, Bala. You can show your share your PPT.
Okay. Sorry, can you see my PowerPoint?
Not yet. No. We are not seeing.
Okay.
You have to go to share screen and then after that you click on the PowerPoint. In the down side, in the tools bar down below, you have this share screen. Click on the share screen. Yeah. Now make it full screen, please. Full screen. Yeah, that's good. It's fine. Fine.
Yeah, we can see now.
Okay. Thank you. Thank you all. Thank you for introduction, Dr. Reddy. It's a pleasure to join this trust. So I've been here in Abu Dhabi since 2014. Before that, I was in the UK for about 19 years. The whole purpose of the talk is to share my experience or our experience so far. To give a little bit of background, the Sheikh Shakhbout Medical City Mayo Clinic is the center for a major trauma center. We receive trauma patients from all over the Emirate of Abu Dhabi. We have about 6 trauma consultants in addition to general surgery and acute care. What I do is I attend every day morning post-surgical take meeting as well with them. So I'm actually lucky to be reviewing all the scans that happened overnight as well. So I will go straight to the PowerPoint. So why this topic? it's interesting as well as very challenging topic. The radiologist is actually the lead in blunt abdominal trauma. So when we say the lead, we have more responsibility in the blunt abdominal trauma. There comes, I make this opportunity with the responsibility. So we have everything in it. So our aim is pretty much to discuss the pearls and pitfalls of imaging in blunt abdominal trauma, and thereby just to share our experience. What do we mean by that? Whatever major scans I'm going to share in this talk, it's all from my collections over the last 17 years. So what are the objectives? So we should approach each and every trauma case as the clinicians approach. So there is a primary survey, secondary survey, and tertiary survey. So we try to follow this, even though sometimes it's difficult. So meaning clinical surveys and radiological surveys. Understand the basic mechanism of the injury and what is our role as a radiologist when it comes to blunt abdominal trauma. And what we are going to discuss today is mainly the pearls and pitfalls. What are the learning objectives? So if we do a CT scan from this topic, we have to have some objectives. When you review a CT scan, is the technique of the scan optimum? Is there an evidence of bleeding? If there is bleeding, does it have to be operative or can it be managed non-operatively, meaning interventional radiology? Is there a bowel and mesenteric injury, or there are signs of hypotension complex, solid organ injury and pattern and grading of the injury, radiological and clinical secondary survey. So these are all just to give the overall picture, what we're going to see through today. So mechanism, when we say mechanism, there are only three types. Basically, one, it's a rapid deceleration. Why should a radiologist should know about the mechanism? It does affect how do you interpret the image. So when you have a rapid deceleration, for example, motor vehicle crash, a tears happens at fixed points. When the patient is involved in a crushing injury, a massive force crushes the contents between the abdominal wall and the spine. Or extreme external compression may suddenly increase the intra-abdominal pressure, resulting in viscous perforation. So these are the three main types in blunt abdominal trauma. We are not going to discuss about penetrating trauma today because that itself is a different topic. So what are the commonly injured organs? So as we all know, solid organs, which are spleen, liver, kidneys, and then move your scale to small bowel, mesentery, urinary bladder, colon, diaphragm, pancreas, and major vessels. I have to be honest with you, we are not going to discuss how to grade an organ injury because it is always there, it's free to access. It is an American Association of Surgery for Trauma. That's what majority of the whole world follows. How do you grade an organ injury? And it's been revised as well. So we are not going to discuss like this is grade 1, grade 2, grade 3. We are not going to discuss that. Okay. I just want to give you a touch on that. AAST has been revised in 2018. And there are three types. We should not get confused among how the injury scoring scale has been done. There is a radiological imaging grading. That's one part. And there is a second part called surgical operative grading. That's the second part. And there's a third part to it. So when you take a liver injury, when we say grade 1, we are radiological. It may be upgraded when they open the abdomen. So that becomes operative grading. Or in pathological, it's a different grading. So we should stick to the radiological imaging grading because it does affect how you interpret and convey the findings in your scan to the clinician. At the end of the day, that's what matters. Okay. So when we come to blunt abdominal trauma, it's a multimodality approach. The whole world follows that. The traditional and the long-standing is a chest X-ray, X-ray pelvis and cervical spine. We still do X-rays, chest X-rays and X-ray pelvis in our center, but we don't do C-spine X-rays as a routine. Ultrasound, it's a fast scan, e-fast scan, they call it emergency fast scan nowadays. They're 99% done by the clinicians at the front gate. So as a radiologist, we are not actively involved in it. The diagnostic peritoneal lavage, it's almost a thing in the past, unless it's you are in a battlefield where it may play a role. So our main workhorse is a CT scan. That's what we will talk about the whole discussion today. We do MRI, but they are in very, very selected problem-solving cases. So MRI is not routinely used because it's time-consuming. It doesn't fit the purpose of emergency scanning in a trauma setting. That's the whole point. So the modality of choice is a CT scan, meaning multi-detector CT scan. It depends how many slices you have, how quickly you can do the scan. And of course, the main thing is, where is your scan situated? Is it next door to your emergency room or far away from the emergency room? That all affects how you do your scan. And what are the types of scan in blunt abdominal trauma? There are two types. One is a pan scan, which is a whole body scan, which are mainly reserved for level 1 trauma cases. We class here as a level 1 and level 2 traumas, meaning if it's a severely injured patient, the ambulance and the receiving clinicians declare that code throughout the hospital. We are receiving a level 1 trauma case. And accordingly, the CT scanner will be ready to receive the patient. So when we do the whole body scan, we do a non-contrast CT head and face, followed by an arterial face, neck, chest, abdo-pelvis, and then portal venous, abdomen, and pelvis. Delayed scan for renal tracts in selected cases. We don't routinely do it. I will tell you why. Why CT scan? Because it's quick, it's available, it's next door to your ER. People have plenty of experience with CT scans. That's the main reason. Okay. And also, it plays a vital role in finding the source of bleeding, which is the commonest killer in trauma, basically. So CT scan gives you the answer most of the time, not all the time, most of the time. So what are the two types we need to know? Active bleeding. What do we mean by active bleeding in a CT scan? When your intravascular contrast extravasation gets bigger on a delayed imaging, and the Hounsfield unit matches the intravascular contrast, that is more than 100 Hounsfield unit, you have an active bleeding. What are the other types of bleeding? It's a pseudoaneurysm or an AV fistula. This is a pooling or a focus of contrast. I will show and discuss in detail when I show the scans. So this is where we play a crucial role. Is it actively bleeding or can it be managed by interventional radiology, meaning without opening the abdomen? So get the scan right. So this has been so many times revisited by radiology literature. Arterial face followed by venous abdomen pelvis. This is the traditional one, and we still follow that. How do we do it? We give 100, 150 ml of iodinated contrast through a good peripheral cannula. I mean, I can't prescribe an exact timing. Every scan depends upon how many slices you have, how upgraded is your scan is. So usually late aortic phase, which is like 25 to 30 seconds from skull base to upper thigh. And then a portal venous phase, which is approximately 65 to 75 seconds. As I said, there is no prescription. Okay, each scanner is different. Patients are different, young patients, cardiac status. So it all affects how you time the scans. So this is just to give you an idea. No need to give oral contrast. We don't give oral contrast at all. Why is that? This is a good publication that was done in the British Journal of Radiology in 2016, based on all these wars that were happening throughout the world. So what their prescription is, time spent by each patient in the scanner room should be less than 10 minutes. So this is what the ideal scenario is. But unfortunately, we don't live in an ideal world. But at least we should aim for this. Then only we get close to it. Because that's only the clinicians like it. Because people always say we delay. You know, the CT scanner causes delay. Actually, it's not. Okay, patients are never at fault. Our scanner and the location of the room, the preparation of the room is the crucial thing. All our technicians should be trained how to receive these people with the clinicians inside the room. You know, so we have to have a big team effort. So as a ballpark, you can say if you're starting a trauma scanner in your unit, you can say 15 minutes maximum. So you should not spend more than that. But the ideal time for this whole body scan is maximum is 10 minutes. So this is a good old our statistics in 2015, but we have way past it now. So we do at least 200 pan scans per month. The age, this is the key. The age which patients get involved in the trauma is between 20 and 40, meaning they are the young patients who are otherwise fit. Most often they are the sole breadwinner of the family. So we have a huge responsibility. The primary mechanism where I work now is two groups. One is a fall and another one is a MVC. So again, before we do the scan, we need to question ourselves. So can I get the technique right? Is my team is ready to do the scan? And then answer the questions. So we go straight to the scans first. So thank you for listening to me so far. I guarantee you now, there won't be any more text. It will be only scans. So what do you mean by pseudoaneurysm? Why are we so interested in it? I mean, there used to be like an old saying, when I was SHO in Manchester, we routinely do a follow-up ultrasound because people who are involved in trauma, they come in, they do a scan, patient stable, get discharged, repeat ultrasound after 2 weeks, 3 weeks, 4 weeks. Why? There is a quote saying, delayed rupture of spleen, delayed rupture of liver. Actually, if you think logically, why would a normal patient's spleen or a liver rupture spontaneously? Then the answer has fallen by itself, meaning it is not the organ that ruptures, it is a pseudoaneurysm that developed during the process of trauma that gets bigger and bigger and bigger and ruptures. So our whole aim is to identify these pseudoaneurysms. So this is a patient involved in a trauma. I will use my marker here. Arterial phase, contrast predominantly in the arterial phase. You can see within the spleen, there is a pooling of contrast, sudden pooling of contrast within the organ. I don't know what it is. We just do a venous phase, which is arterial to venous phase. You can see that that becomes iso, almost iso, amongst the region of lacerated spleen. Okay, so the size is the same. It becomes iso to the parent organ so that it's not increasing in size, in contrast to active bleeding. So if you look on the coronal, again, perisplenic hematoma, everything, pseudoaneurysm, that becomes iso. So what happens to this patient? This patient goes straight to interventional radiology, catheter in. So what do you mean by pseudoaneurysm? Again, so you go from your native arteries to the periphery. Physiologically or anatomically, your arteries should be smaller as you go to the periphery. But if you look at the normal splenic arteries within the branches, the marginal branches, they are getting smaller and smaller as you go to the periphery. Whereas the pseudoaneurysms, see, the CT scan showed 1. When you do an angiogram, selective angiogram, you're seeing 2. Okay, so this is a classic example of a pseudoaneurysm. It happens during the process of blunt abdominal trauma with a liver laceration. So they go in, they embolize, they come out. No laparotomy done in this case. But always the decision is a combined decision. How is the patient at the time of the presentation? So this is another case. Again, you can see here, this is spleen, which is a little bit bigger spleen. You have hematoma, you have hemoperitoneum. You don't see much in the arterial phase, but there is a laceration. On the venous phase, there is a well-defined rounded focus, pooling of contrast within the parenchyma that the Hounsfield unit is matching the native organ. Okay, so again, it's the same on the coronal plane. Go in with angiogram. That's the pseudoaneurysm. Okay, it gets embolized. The job is done. So this is another patient. If you look on this liver in segment 6, which is the inferior aspect of the right lobe of the liver, if you go down the route of AAST criteria, this becomes a grade 1. But if you look at the revised AAST criteria, if there is an intraparenchymal active hemorrhage, it becomes grade 3, no matter what the size is. If there is hemoperitoneum, it becomes grade 4, no matter what's the size of the laceration. So what I'm trying to say here is, it is not just purely the size of the laceration. You need to know what happens inside the laceration. Is there active bleeding inside the organ? is there an active bleeding outside the organ? Meaning it's a small size laceration, but the patient is bleeding. Okay, so go in with angiogram, you can see that that's bleeding outside into the peritoneum. Okay, that's been embolized. So no surgery. So this is another patient. You can see the subcapsular hematoma, pseudoaneurysm, again pseudoaneurysm, angiogram, embolized. So hopefully I have convinced you the role of radiologist in identifying these pseudoaneurysms. So this is another patient. So far I have shown you the organ, meaning visceral pseudoaneurysms. So now we have to look at outside. What happens outside? Okay, in the retroperitoneum, free retroperitoneum. This is a patient who is involved in a trauma. So big retroperitoneal hemorrhage, fracture, and then you can see this, like it looks like a active bleeding. Okay, this was actively bleeding. So patient went straight to, because it's a retroperitoneal bleed, went for an angiogram. They couldn't find it. They couldn't find this because the patient physiologically responded, vasoconstricted, everything, hemodynamically stable. So they just did every lumbar angiogram and came out. They didn't want to disturb the physiology as the patient remained stable. Okay, so 2 weeks later, so patient had a spinal, pelvic fracture. You can see the fracture here. So, okay, 2 weeks later, patient complained of back pain. We did again angiogram. The hematoma became more organized. Now it becomes a very well-defined pseudoaneurysm. So this is the follow-up angiogram. You can see the pelvis was fixed across with a screw. Now you go in and embolize it. So because of your first scan that picked up this active bleeding, it gives an idea to the, the medically responsible in charge person of the patient knows there was an active bleeding, no action was taken, so we can follow this up. So this is what the whole purpose of this talk, not to miss these findings, because that's the whole purpose of doing a scan. Okay. So active bleeding. So we touched so much about pseudoaneurysm. What is active bleeding? So I will give you just a couple of examples. So this is a patient involved in blunt abdominal trauma. So you can see retroperitoneal hematoma on both sides, parasovus here in the true retroperitoneum. So you can see a tiny bleb here. I'm not going to scare you to say to identify this sort of bleeding. But if you look on the venous face, it gets bigger. Okay, that's one area, but it's a small bleed. Why would the patient be so compromised? So you look again. So on the other side, within the psoas, there is further focus of active bleeding that gets bigger on the venous face. Now, you can see this retroperitoneal hemorrhage everywhere, basically. Intraperitoneal patient was fine. This gives you an idea. I use fractures, like when you see displaced transverse fractures, not every fracture of the transverse process gets hemorrhage in the retroperitoneum, but it gives you an idea where to look for. The bony landmarks is not only for anatomy, but also for the radiologist to go and look that region. Is there a sign of bleeding? Is there a hematoma inside? I can put my, verdict here to say the first few minutes of the patient is crucial about the next few hours. And that next few hours is actually the deciding factor for his life. So if you see these fractures, like grossly displaced transverse fracture, look at the kidneys, look at the retroperitoneum, is there active bleeding? So because these fractures, nobody does anything about it. Nobody fixes these fractures. But what happens to the patient is the inside, okay, the bleeding, the retroperitoneum, the kidney, all these things. So again, this patient went for an angiogram, embolized. Can you have both in the same patient? Of course, if I know the formula of every patient, then I should not be a normal human being, meaning patients don't read textbooks. So this is the patient, this is from last, like 6 months ago. You can see this is the arterial phase. You can see the heterogeneous splenic enhancement, small areas of laceration through and through the spleen. This is a contrast pouring outside the organ, okay? Arterial phase, and you look on the venous phase, that gets bigger. That gets bigger and more denser. That is active bleeding. That is active bleeding, not a pseudoaneurysm. Okay, so perisplenic hematoma, active bleeding. And then if you look on the coronal spleen, as again, outside, just around the capsule, active bleeding in the arterial phase, that becomes bigger on the venous phase, okay, actively bleeding. Now look at the same patient, okay? There is something happening inside the organ, Okay, so focus of contrast in the arterial phase, that becomes ISO on the venous phase. Looks like a native organ, but surrounded by laceration. So you have a pseudoaneurysm and active bleeding. Okay. So again, angiogram was done. You can see the pseudoaneurysm here nicely. So that was again, he had full embolization. He had main artery as well as selective artery. So far, I hope I have convinced you to look for a pseudoaneurysm versus active bleeding in a patient who is involved in a major trauma of level 1 trauma or a severely injured patient. Why do we need a dual phase? I have so many challenges to come across all these years to set these guidelines. As we get better and better, people might say, I just need single phase. You may be right, but what I'm saying is we have to look at our colleagues, because I have 24 radiologists with me, and I need to make sure everybody can make this diagnosis. That's what matters at the end of the day, not Dr. Bala who makes the diagnosis. No, can his whole peers can make the diagnosis, make sure they are all in the same boat. So this is a nice, review article that came in 2013, still the best one. It tells, when they use the arterial phase alone, when they use the portal venous phase alone, how much the percentage they're getting better and better. So these are all the experts that have reviewed individual scans, and then both scans together. Obviously their confidence interval on this percentage of picking the abnormalities was so much different when they used dual phase. So that's about the active bleeding and pseudoaneurysms. So now we're talking about the bowel and mesentery. Okay, so if you look at the CT scan here, so again, I'm only showing the selected images, but they're all our scans from my experience. Okay, so if you look at this scan here, coronal plane, single shot, arterial phase. So predominantly the solid organs are normal. Okay, you can come to the right iliac fossa. There is hemoperitoneum in the right iliac fossa. Okay, and keep an eye on this area here. There is like an active bleeding in the right iliac fossa mesentery. And the axial plane, you can see that there is hemoperitoneum, okay, and active bleeding. That's mesenteric injury. Right iliac fossa, mesenteric injury. Now go back to your mechanism of the injury. Okay, when I say two fixed points, one is the right SI joint, the other one is the duodenojejunal flexure. That's where the mesentery, starts and attached to the back of the retroperitoneum. So this is where it tears. Okay, so this is the key finding. Okay, so right iliac fossa hematoma, active bleeding in the mesentery is equal to mesenteric injury. Okay, there is no compromise on that. You have to be very strong with these findings because it is there. It's always there. To be honest, it's always there when you go back. So if you look at the venous phase, you look at the bowel enhancement everywhere. Okay, you look at the bowel enhancement. They are nice, normally enhancing. Come to the right iliac fossa bowel. They are starting to lose its enhancement, similarity to the left upper quadrant bowel. Okay. Now you look at this bowel here. They're starting to people give so much importance nowadays to, the small bowel feces sign. Basically, it is a very sensitive but not very specific. So this small bowel now contains feces-like thing, meaning they are not moving. Okay. So that's telling you mesenteric injury, mesenteric hematoma, mesenteric bleeding, the adjacent bowel is starting to get sicker. Okay, this message needs to be conveyed to the in-charge clinician, i.e. the general surgeon. Okay, so don't just say there is a bleeding. You have to add the word called mesenteric injury is highly suspected. Okay, so this is another patient. Again, you can see here, this is a sigmoid colon. So you have a sigmoid colon and the transverse colon, they can flop around anywhere in the abdomen because they are on a big mesentery. Okay, so this is a sigmoid mesocolon and a hematoma. Look at the coronal plane, sigmoid mesocolon. All around it is hematoma. Okay, how can I be sure that that colon is not involved? We cannot be sure. Okay, and also we should not wait for him to develop fecal peritonitis. That makes the surgeon's job very difficult. But when you convey this finding, where is the center of the epicenter of the injury is sigmoid mesocolon, big time hematoma, no free gas outside the colon, but the colon itself is thick walled. That is the cardinal finding. That's a cardinal finding. That is, you cannot, I cannot stress more than that. Seatbelt sign. The clinician will tell you patient is involved in MEC, external injury, they might have a seatbelt sign. We can actually see the seatbelt sign, okay, in a CT scan. This is actually the anterior most part of the subcutaneous abdominal fat. You can see that injury here, you can see that. So when you see this, you slow down your face now, okay, because the impact may be huge. Okay, now you start look at the abdomen, okay. Now look at this right lower quadrant. There is inflammatory stranding around the mesentery. Okay. Now you have hematoma on the right iliac fossa mesentery. Okay. So seatbelt sign, right iliac fossa mesenteric sign, convey this message to the clinician. So they might opt for a follow-up, close observation, but this message needs to be conveyed very clearly in your report. Okay. This is another patient. You can see the solid organs are normal. You have a big amount of hemoperitoneum around the liver. You can almost see there's a layering. Okay. So where is this bleeding coming from? This is where the CT scan beats the ultrasound. Ultrasound is very good in telling you hemoperitoneum, but it doesn't tell you where it is coming from. Okay. Whereas CT scan, if you look into it, you pretty much most of the time should be able to tell. Okay. So right iliac fossa hematoma. Okay, there's a right iliac fossa hematoma, mesenteric hematoma. Now, that's a sigmoid colon. What is this? Okay, this is a coronal plane. You can look at the small bowel here. That's a normal jejunum, normal, nice, enhancing, homogeneously enhancing, collapse, no issues with that. As you come down to the area, you see the hemoperitoneum, the right iliac fossa, hemoperitoneum around the liver. Now, that bowel, as I said, it's adynamic, meaning not moving. Okay. So I need to convey these findings in my report. Right iliac fossa, mesenteric injury with a mesenteric hematoma with an adynamic segment of small bowel, highly suggestive of small bowel mesenteric /tear/injury. Okay. So the whole purpose of this talk is no point in you and me knowing these findings. These findings needs to be conveyed to the person who is in charge of the patient. Okay. So this is another patient. Again, you can see that small amount of hemoperitoneum, solid organs relatively normal, upper abdomen is normal, come down, transverse mesocolon now. You have a mesocolon hematoma, okay? So if you look on the coronal plane, you can see that mesocolonic hematoma, okay? So these are all the findings. If you look for it, you will find it, okay? So hemoperitoneum, solid organs normal, look for the mesenteric injury, okay? So this is one of the great topic I was taught, and this basically it's inside my brain nowadays. Okay, this was taught to me by mentor in 2004. Tiny bubbles, big troubles. In any CT scan, not just trauma, any CT scan of the abdominal and pelvis. So you have to look for it. Start your eyes to look for it. Okay, so this is CT abdominal. For a blunt abdominal trauma, you can see this tiniest bubble of free gas. Okay, pneumoperitoneum, you can call it extraluminal gas, but this is an intraperitoneal gas. Okay, the coronal plane, that's where it is. Okay, you can see that little bit of stranding here. So remember the mechanism of the injury now. The DJ flexure and the right SI joint. This is how usually the mesentery is attached, okay, in a diagonal pathway. So this is a patient. This is not a mesenteric injury or a trauma. This is perforation. This is definite perforation. I told you this is a blunt abdominal trauma, not a penetrating trauma. So in a blunt abdominal trauma, if you have a stranding in the mesentery or inflammatory mesentery or a misty mesentery with extraluminal gas, you are home and drive actually. You are pretty much, you have the full house of the findings in your scan. This is another patient. This is just from last month actually. So if you look at this coronal plane, solid organs pretty much okay. Come to the right iliac fossa, right side of the pelvis. You're starting to see some hematoma here. Okay, that's the tiniest bubble of gas. Look on the axial plane, again, this is extraluminal gas that's outside the bubble. Look at the enhancement difference. This is normal enhancement of the small bubble. This bubble is not at all enhancing. Okay, this is full house. This is perforated small bubble. Look at the SI joint on the right side. Diastased. Okay, so Now, if I see a diastasis or widening of the sacroiliac joint, I start looking what's inside. Okay, because as a human being, it always gives you a clue. If there is an injury here, look at the bone. If there is a bone, look at the bowel. So that's what I'm trying to say. Okay, you can't escape one or the other. Okay, that's why the understanding the mechanism of the injury is crucial. So on the coronal plane, I can convince you, you see that jejunal loops are nice normal enhancement in the venous space. These bowel loops are not at all enhancing. Okay, so that is Radiologist foresaw small bowel mesenteric injury with perforation with non-enhancement of the bowel. This is another patient. You can see here, this is a tiny bubble just around the splenic flexure region. Look on the coronal plane, is just below the spleen. Okay, tiniest bubble. Okay, another patient, tiniest bubble. Why I'm showing tiny bubbles? Imagine these patients are otherwise fit and healthy just the seconds before the accident or the trauma happens. So they were normal people. Okay, normal, young, fit and healthy people, usually. Okay, when they come in with trauma, their body reacts and helps, the physiology reacts. So you're not going to have the full house of everything. Okay, so they might just starting to develop this peritonism. That's why the quicker we diagnose, it makes the surgeon's life much, much easier. Okay. So this is a patient who's landed in his buttocks, fall from height. So that's your levator arani, the piborectalis coming down, levator arani becoming piborectalis. Now look at this, that gas without any perineal laceration. Okay, you have a gas there, meaning that sphincter complex integrity is gone. Okay, when you have a gas outside the sphincter complex without any open perineal tag below the level of the external sphincter, that sphincter integrity should be questioned big time. Okay. Again, this is the patient. Okay, tiny bubble of gas. So I hope I convinced you. So this is published in Radiology in December 2012. What are the signs when you look for it? So if you, for example, if you just rely too much on ascites, the sensitivity is very good. Okay, 90 to 100%. But look at the specificity. It's only 15 to 25%. So you have to start looking the other way around. Okay, the bowel wall discontinuity, extraluminal air, focal bowel wall thickening, abnormal bowel enhancement. Okay, these 4 things place highly specific for the organ damage. So we need to look for it. Okay, the challenging areas in the CT scan. As always, it's very, very challenging when it comes to the hepatopancreaticobiliary region. Okay, so this is an axial CT scan, portal venous space. You can see that's the second part of the duodenum. That's a lateral aspect of the pancreas. You can see the laceration through it. It's very, very difficult on the first scan to say what is intact and what is not intact. So the way we have an understanding with our clinical team, when we say there is a laceration in and around the pancreas going through the duodenum, those patients goes under a tight surveillance. Okay, so this very easy case because you have gas outside. That's a retroperitoneal gas. The job is done. That's a duodenal, pancreatico-duodenal injury with perforated duodenum. It's very easy because it's perforated. But why I'm saying it's difficult, all these patients will have liver laceration, renal laceration, hemoperitoneum. So our eyes gets distracted, right adrenal hemorrhage, right renal laceration, right liver laceration. So we get distracted when you look at these scans. So have a small boxes in your wish list when you go through the CT abdomen. What the things that you don't want to miss. That's why I put it in my first slide, the learning objectives. So if you look at this scan here, right lobe liver large laceration, but there is retroperitoneal fluid. Okay. But when you see this left lobe liver laceration, how often you see left lobe liver laceration? When you see left lobe liver laceration, bring your gears down, move from 4th gear to the 2nd gear, slow down, because the impact is in the epigastrium. Okay, that's where back of this is the pancreas. Okay, so unless we think like that, we will miss it. Okay, commonest lobe involved is the right lobe. When you're starting to see the left lobe liver laceration, change gear. look for the, pancreatic injury. These are all difficult areas. This is another patient, left lobe liver laceration. So I said, go backwards, retroperitoneal hemorrhage, splenic laceration, very straightforward. Your pancreas is pretty much transected. Okay. So what I'm telling you is not theories, it's there. It's a false proof, basically. When do we use MRI? This is like a few months ago, we had this case, just exactly the junction of the left, which is like a falciform ligament area. There's a laceration going through and through from the front capsule to the hilar region. Okay, laceration from the front to the back, up to the hilar region. So we told the clinicians that there is a laceration through and through. There is high risk for involvement of hilar vessels. Of course, we are not going to diagnose bile duct injury, but it's very hard to imagine that bile ducts escape this. So this patient was kept under close surveillance. Okay, pancreas was normal. 3-4 times we revisited this area. The pancreas was normal. Okay, there is no extraluminal gas. So 2 days later, we did MRCP. Pancreatic duct is absolutely normal. Extrahepatic bile ducts is also normal. Okay, but the patient starting to develop now small ascites. Okay, that's where the laceration is. So we decided, surgeon asked us a question whether should we operate or go back in. Okay, so we decided to give Primavest, which is the hepatobiliary contrast. Okay, so this is a non-contrast MRI, non-contrast MRI. I'm just keeping it simple, basically. And then we do a 20-minute delayed sequences for the hepatobiliary contrast. You can see the hepatobiliary contrast is leaking out. Okay, so that's where the laceration is. Okay, to the bile duct. So we got this right, not because we got the scan, because our way of thinking is the same. Okay, left lobe liver laceration through and through to the hilum. How come the bile duct can escape? Okay, so you have to prove one or the other way. Bile duct intact, bile duct is leaking. The sooner the better, because it makes the surgeon's job much easier. So this patient, after a lot of discussion in a multidisciplinary team, they just went for the ERCP. They wanted to divert the bile flow. Luckily, patient survived without laparotomy. So, overlooked diagnosis. Can we miss it? Yes, of course we can miss things because we are all human beings. And you are looking at 100 things. You are looking at 1,400 slices of scan, and the report should be issued within 20 to 30 minutes. Okay, because that's what matters. So if you change, look at this scan. This was missed. Okay, so pancreatic transection. Next day, it was very straightforward. Okay, when your mind is calm, your findings are different. When your mind is not calm, your findings are different. I don't need to, there is no other explanation for this. Okay, this is $1 million question. Can we repeat the scan to assess for extraluminal air in suspected bowel injury? Yes, we can, but when? What is the time frame? I don't know. There is no prescription. Some people say minutes, some people say hours, some people say even days. But if you put it together with the clinical assessment, it's much easier. But the clinical assessment also becomes difficult in a low GCS patients or patients who are intoxicated with, for example, alcohol. Then the clinical assessment becomes tricky. So this is the patient. I'm just going one example. This is an arterial phase, big time laceration, liver laceration, splenic laceration, hemoperitoneum. Okay. So watch this area. This is arterial phase. This is like a little delayed phase. Free gas developing, okay, in between the arterial and the venous phase. That's what I'm saying. I can't prescribe when to repeat the scan. Okay. So this patient, of course, it's a through and through fracture. Okay, through the fracture of the vertebrae, posterior elements, anterior elements are involved. So it's a big injury. Isolated bowel injury in blunt trauma is only up to 5%. Okay, the incidence reaches up to 34% when there are more than 3 organs injured in blunt abdominal trauma. Why I'm saying that is when you get distracted with the liver laceration, splenic laceration, or a renal laceration, or pancreatic, we get distracted and we miss this important, small, but pertinent findings in the scan. So this was published. Okay, so this is an example. Okay, so renal laceration, intraperitoneal fluid, extraperitoneal fluid. Okay, so liver laceration, same patient. Okay, renal laceration, liver laceration, adrenal hemorrhage, okay, right iliac fossa mesenteric injury, hematoma, okay, and the tiny bubble of gas. Okay, the tiny bubble of gas in the right iliac fossa. So you have a small bubble mesenteric injury with perforation, you have a renal laceration, you have liver laceration. Of course, the reporting radiologist was very happy, no issues, went home. Patient was operated, got better, discharged, came back 3 weeks later, okay, with this scan. After a small bowel anastomosis, that's the reason we gave oral contrast, okay, because patient had a small bowel anastomosis, we gave oral contrast. So there is intraperitoneal and extraperitoneal fluid, enhancing fluid collections. So the radiologist was reporting a scan, was very clever, did a delayed scan. That was because the radiologist thought there was a renal laceration. So it is a leaking of urine, okay? It's a leaking of urine. So it's confirmed, nephrostomy was done and patient was managed. So far I've shown my experiences of the different aspects of CT blunt abdominal trauma. This is another one area, why it is important. How do you understand the science of hypotension complex? Because it affects the way you interpret the scans. So you can have a collapsed IVC, small aorta, bowel enhancement, abnormal enhancement of the pancreas, hyper-enhancing adrenals, halo and IVC. Initially, it was thought to be a high mortality. When it came in 2006 to 9, and the publications came out of this, the mortality was thought to be higher. But as we get better and better, people are picking these signs up in most of the acute scans. So the mortality is not what it used to be because we are very good in picking it up. Now, if you look at the Canadian Association of Radiologists journal in 2013, they propose imaging signs of hypotension complex happens even before the clinical signs. Okay, so compensated imaging signs before the clinical signs because these are fit people, normal young fit people. Decompensated mean the clinical signs is developed, i.e. tachycardia, hypotension, everything. And then the third group is irreversible. Okay, this irreversible group has a poor prognosis. Okay, when you say poor prognosis, up to 70% mortality. How do you know this irreversible? When your kidney does not enhance with the contrast, or when you see a hollow sign around IVC, then that's the worst outcome for the patient. So I'll just share a couple of examples. You can see that flat IVC, okay, small aorta, okay, flat IVC, small aorta because of the retroperitoneal hematoma, okay. Now hyper-enhancing adrenals, okay, flat IVC. That's because you can see even the polycatheter has gone through the intraperitoneal ruptured bladder, okay. So that's coming out, basically. When they put the catheter from here, it was going out through the perforated bladder. So this was a signs of hypotension complex. Don't forget this is another group. We are facing this very often now, vasopressors, inotropes, because we learned a lot from during the COVID era, okay. So imagine patient is on high dose of vasopressor. This is how your splanchnic circulation will look like, okay. The celiac gets smaller and then just sudden abrupt cutoff to the SMA, okay. So we need to be aware of these things, okay. That's because of hemoperitoneum. Patient was on all sorts of inotropes. That's what happens. Small aorta. Shock bubble. Sometimes we get fooled with these appearances, okay. So hyper-enhancing mucosa of the edema. This is a patient who was, GCS was 5 because of significant head injury. This is a new kid in the block. We need to be aware of it. It was published big time in radiology, cocaine, opiates, cannabis, amphetamines. All these drugs can affect how your scan looks like. So you need to understand the vasospasm, everything like inotropes, at least some major idea of knowing these things, what these drugs can do to the way of organ enhancement, the central organs, the vessels, how they become tapering, sudden cutoff. So we just need to have some idea, because don't forget, people who are involved in trauma can also get involved after taking these recreational drugs. The last but the least is the ascites. I think I'm almost there. So ascites, systematic approach is crucial. Okay, believe me, ascites is a systematic approach. And of course, ascites is not a diagnosis. It's just a finding. Okay. So this is a patient who was admitted with us with the blunt abdominal trauma, who had a previous, gastric bypass. It's a bariatric surgery. We have a little bit of hematoma here, little bit of hematoma, nothing much. Okay, ascites in the hepatorenal pouch, no free gas, mesentery clear, solid organs clear. So the patient was consulted for, exploratory laparotomy, because that we don't know what's happening here. But the patient on the day one, he refused because he had some bad experiences with his previous laparoscopy. So the surgeon decided to sit tight, keep him near by mouth, and repeat the scan the following day. So the following day, we gave oral contrast because we had all the time in the world. So we gave the oral contrast in the ICU and brought him down. Now the fluid is increasing, the ascites is increasing. Now the gallbladder looks very abnormal. Okay, the gallbladder is very abnormal, the high density within it, with the loss of continuity of the gallbladder wall. So we use the magic term, pancreatic or biliary complex injury, but here it's pretty easy because we have the day before we have a scan. So we can compare with that scan and this scan. So the only new development is more ascites, gallbladder looked abnormal, and this was confirmed to be a perforated gallbladder from previous ablations. This is another patient who came in with ascites, okay, otherwise normal, solid organs normal, you can look at here, pelvic ascites, abdominal ascites, no hemorrhage, no extraluminal gas, solid organs normal. But don't forget this, okay, there is a SI joint diastasis, and then, anterior and posterior column is gone in the pelvic fractures. So if you imagine a fracture going from front to back or back to front, how can the organs in the middle escape? That's very lucky to be escaped, but we just need to work it out, okay? So normal, the reason I'm showing this scan, just normal contour of the urinary bladder doesn't mean it's normal, okay? So the radiologist said, bring the patient after 20 minutes. That ascites is just urine leak, intraperitoneal bladder rupture. You can see here, completely bladder pouring urine into the peritoneal cavity, okay? There's an intraperitoneal rupture. So this confirms, pelvic fracture, ascites. Don't get satisfied with that. Just keep looking, or at least put that one word in your report saying, patient was too unstable to keep the patient in the scanner to do a cystogram. Consider bladder imaging, as we haven't found a cause for the ascites. So that's what I meant. It's no good in me knowing all these things if I'm not conveying these findings to the reporting clinical doctor. So they need to be aware of that, because everybody gets busy. Okay, so this is another patient with the pelvic fracture, diastasis, okay, diastasis, pelvic front and back fractures. So this time, this patient had a time because hemodynamically stable. After discussion, we kept the patient, did a cystogram. Cystogram was normal. So we proved, nothing is 100%. We proved to a certain extent the bladder integrity is maintained. This is another patient. So what do you mean by urinary bladder injury? So there are two groups, extraperitoneal rupture, which is the commonest one, 80 to 90% of the time, or intraperitoneal rupture, which is 10 to 20%, okay? There are plenty of guidelines out there, whichever guidelines you want to follow, European Association of Urology, American Association of Urology, Radiology, plenty, but follow some guidelines, but make sure the guidelines you agree with your clinical peers, okay? They understand and we understand, we follow the same. That's all it matters. Criteria, the major versus minor criteria for doing a cystogram. If you have a pelvic fracture with a visible hematuria, that patient should have bladder assessment or a renal tract assessment. Significant pelvic fracture alone or a hematuria alone. So, and there are plenty of minor criteria, like microscopic hematuria with a fracture, minor fracture with a major hematuria. It comes in all combos. But the point is, when you see a major pelvic fracture with hematuria, we are all responsible. We need to exclude bladder injury. In our institute, how we do it, if the patient is stable enough to be in the room, okay, that green signal has to come from the clinician. We don't keep patients, just we need to have a cystogram, okay? That green signal has to come from the clinician. If he says, okay, patient is okay to be on the CT scanner for another 7-10 minutes, yes, we can do it. Cystogram, you need to inject 250 to 350 ml of diluted iodinated contrast, okay? Ideally speaking, through a periurethral catheter and do a CT. or if the patient is unstable, what we agreed upon locally is patient will go either to theater or ICU. They can do an on-table cystogram, either during surgery or just do at least an X-ray. Okay, so that's like, and you should have a local agreement. So this is a classic example of extraperitoneal rupture. Okay, it's a classic example of perivesical urinary leak. Okay, ascites, I can keep on going. Very small ascites. Nowadays, our scanners are much better. You know, they come up with all kinds of softwares, low dose, high resolution, quicker scan, less contrast, fast scan. Ultrasound is getting better. So we are finding these ascites nowadays, even in male patients. You know, 3 to 5% of young male who received excess IV fluid during resuscitation may develop just normal ascites. But recommendation is clinical follow-up. So ascites, as I said, it's not a diagnosis, it's a finding. Okay. Last but the least one, avoid satisfaction of search. Okay. This is from 3 weeks ago. Okay. I think I can see the date there. Okay, 2023 March. Patient came in, blunt abdominal trauma. You can see the left upper quadrant is hematoma, left renal laceration, right iliac fossa not looking good. So renal laceration, splenic laceration, and then right iliac fossa. You can see here herniating outside, meaning it's a massive increase in the intra-abdominal pressure. The intestinal contents are herniating, but without external skin loss. Okay, so intra-abdominal increase in pressure with the hernia, the right iliac fossa, left renal laceration, splenic laceration. And then the radiologist at the time spoke to the clinician, wanted to do a delayed urogram, did the delayed urogram. You can see that that urine is leaking out. Okay, urine is leaking out. Okay, urine is leaking out. Nice pickup. So you have all full house. And watch out this one here. The arrow mark, I put it there. Flat IVC. Okay, the flat IVC is telling you the patient hemodynamicity is okay. How do you know it's okay? Because we don't normally keep the patients on the CT scanner for 10-15 minutes if the hemodynamic is unstable for doing the urogram. Okay, so that telling you that the hypotension complex can appear even before the patient clinically develops hypotension complex. So full house, full tick marks, all done. Okay, renal leak and everything. Okay, so all done. But what happened is we missed this. We missed this urine leaking into the pleural cavity. Okay, urine leaking into the pleural cavity. How do you know it's leaking into the pleural cavity? We were satisfied with our search. Okay, that's the problem. We were satisfied, you know. Now the urine contrast is looking into the pleural cavity. Meaning, what is it telling you is the diaphragm there is gone. Okay, look at the right hemidiaphragm. The left hemidiaphragm is gone. Okay, so sudden increase in intra-abdominal pressure caused hernia, caused renal laceration, caused splenic laceration. So we diagnosed all those. We even diagnosed urine leak, but we got satisfied. We got satisfied with all our findings. We missed these two. Okay, luckily it was picked up on the day after review scans, and then it was dealt appropriately. So avoid dissatisfaction of search. Okay. Okay, so this is another one patient who was involved in abdominal trauma. Okay, so people think it's okay, it's nice and easy. So you have fracture of the posterior elements, fracture going through the vertebrae. Okay, then look at this aorta here. That's an aortic injury, abdominal aortic injury. Okay, that was blunt trauma. Penetrating trauma, I'm not going to talk, just one slide. Surgery is still the key first choice in unstable patients. Why is that? This patient needs a modified protocol. You need IV contrast, oral contrast, rectal contrast, renal tract, everything. It's like totally a different approach in penetrating trauma. Okay. So this patient, I'll just go in an example, extensive pneumoperitoneum. Okay. Extensive pneumoperitoneum, you can see that herniating omentum outside the abdomen. If you look at the axial, it's just popping out. The omentum is popping out. So we initially thought this is free gas, omentum popping out, abdominal hollow viscous perforation. Surprisingly, there was no intestinal perforation found during laparotomy. So that's what I'm saying. In penetrating injury, when the peritoneum is violated, okay, they don't follow your rules of free gas and stranding and mesenteric hematoma because the organ has sustained a penetrating injury. Pregnant patient, I will just go touch this one. The best way to take care of the baby is to take care of the mother. If you understand this magic word, you will survive. Okay. So what do you mean by that? In severe maternal injury, it's a maternal mortality. In minor injury, it's a placental abruption. Okay. So minor injury recommendations, I don't know whether many hospitals follow this, but this is a recommendation from the College of Obstetrics. Pregnant patient needs at least 4 hours of fetal monitoring before discharge. Why is that? Fetal distress is often the first sign of maternal hypotension. So stratification, you have your own way of doing scans, ultrasound, x-rays, follow-up, repeat ultrasound, watch out for hematuria. So I'm saying, don't just overreact to the fact that the patient is pregnant, okay? It's not an absolute contraindication not to do a scan or not to do x-rays, okay? Because you're responsible for 2 lives there. So, but you need to follow what's your local agreed protocol or national obstetric organization guidelines. But what matters is the clinical discussion. Clinical discussion is what matters, that we all agreed what we are doing is correct for that particular patient. This is a publication that says here, the whole body CT scan equivalent to 3 years of natural background radiation and is associated with no increase in anomalies or growth rate restriction. That was published in 2000. Okay, so the publications are there. So for a matter of time, I'm just moving. So pitfalls and pearls. Ascites is a finding, not a diagnosis. So be exhausted to find the cause and may need a follow-up imaging. Gallbladder, pancreas, duodenal injuries are challenging areas to diagnose unless we look for it. Pelvic fractures, look for urine leak, delayed CT or a cystogram. Bowel injury usually warrants surgical intervention. I'm saying usually, not always. Okay. Look for the tiny bubbles. The tiny bubbles of extraluminal gas. You are home and dry. Okay. Understand the technical factors. Is my scan techniques correct before we can blame? Or is there a patient factor, like a hypotension complex, patient on inotropes, patient on vasopressors, or patient under the influence of recreational drugs? Okay. This is my magic word. A second look is as good as a second opinion because patients often don't get a second chance. Okay. So summary, whole body scan will keep on increasing in future. Teamwork will only work with an effective leader. Avoid satisfaction of surge, and imaging is not a substitute for a clinical examination. And this is the most recent radiological publication in 2019. Okay, the whole body CT scan after MVC crash. There is no added benefit after high energy impact with normal physical and clinical examination. There is no role. Okay, but who is going to be the responsible person for doing this normal physical and clinical examination? And thank you.
Thank you, Dr. Bala, for an excellent presentation. As always, you are a great speaker and you really bring out some positive and very interesting findings and your personal experience. This is really highlighted well. Your summary was fantastic, like what is the key areas to look for. I really liked that your second opinion is the best. A second look is the second opinion. And that is always important. Like we should always go back and look again to give the maximum benefit to the patient and the clinician. I request any comments, questions. Dr. Vijay Bhaskar?
None, sir. That was a very great presentation, sir. Out of his experience, I mean, this is one of the best talks I've heard about approach to trauma and all the subtle signs and very, very valid points he brought out. So it's a great listening, learning experience. Anything from the audience? Anything from the participants, please? Anyone?
And thank you. I mean, basically, we are still learning because when When we start to think we know everything, that's the day we quit radiology. I think it's patients teach us everything, basically. Not everybody follows textbooks, not everybody follows guidelines. It's just that communication keeps you more confident at workplace. It's not about picking up a fancy diagnosis. It's about, can I convey my findings to the clinician? Can I convey my findings in the report to appropriate person? What matters? That's basically the bottom line. That's still I'm learning. Sometimes it's very difficult to satisfy the team, clinical team. They always come up with this, you come up with 9 diagnoses, they always come up with you missed the 10th diagnosis. So they are a very difficult bunch to keep happy. But that's our challenge. But I have to accept that, compared to 2006 when I started my job, now we are actually the front driving seat. The radiology you take from stroke to anything, radiology is the driving factor. It is the front runner. It's almost close to the front gatekeeper. So with the it comes with big responsibility as well. So that's what I enjoy about radiology.
Thank you so much, sir. Sir, we would request your permission to host this video on the YouTube channel of our KREST. Is it okay, sir, for you?
Please do. Please do.
Yes, sir. Thank you very much, sir.
Thank you.
Just one comment. Actually, may not be related exactly to this topic, but today in the morning newspaper, Telangana government has coming out with 47 or 50 trauma centers throughout the state.
Okay.
And this are following the Tamil Nadu model. Anyhow, what I want is actually a major part of this trauma centers will be radiology. What I read in the newspaper is there will be a tertiary hospital and there will be satellite centers in every district.
Yeah.
Can you give us some idea about like what should be the equipment or how should they plan, just for general information?
I mean, I will tell you one good example that in 1997, I was a medical SHO. We sent one patient for a CT scan, and in those days, the buildings were like little islands, like 1 kilometer away from each tertiary. So the radiologist said, refuse to do the scan because the patient is too unwell. Patient is too unwell for the scan. In fact, that is the patient who needs a scan. Yes. So we need to set up the emergency radiology next door to the emergency. That is no compromise. There's no compromise in that. If you don't put your radiology next door to the emergency room, I think we will lose the battle. Okay, as soon as the patient is received, resuscitated, there's a trauma team sees it, or emergency physician sees the patient, receives the patient, declares patient is fit to go for a CT scan, then it's a CT scan. Why is that? Because nowadays, every team is broken into pieces, meaning you have neurosurgeon, you have spinal surgeon, you have general surgeon, you have thoracic surgeon, you have orthopedician. So one patient, one scan, you have to keep all this group. So they come and say orthopedic, no fracture seen, they will go. So individual people will come and go. So we are the only person who sits in the middle with the full details to convey the message. So the radiologist should be actively involved in setting up it, along with your technicians. Like a resuscitation should be your CT scanner room in our hospital. They can do complete resuscitation inside the CT scanner room. It is how it's set up. Big doors, patients come in through doors, full resuscitation kit is available inside the scanner room. The techs are very well prepared. So that is what I'm trying to say. We should be able to receive sick people. If we lose the battle, we lose the whole battle. That is the main thing. You have to convince your management to say, we are happy to receive sick people in your CT scanner room. Your tech should be trained, as well as the ER physician should be trained. That's the main thing.
Thank you.
Because
Thank
retracting sources from the whole body scanner is very easy. You can always go back and do a 3D bone reconstruction the orthopedic wants, that reconstruction the spinal surgeon wants, that reconstruction the skull surgeon wants. So it is very easy. So that's most important thing. Many hospitals in the initial days failed the trauma visit. The scanner was in the wrong place.
Thank you, Dr. Bala. If there are no comments, then I request Dr. Vijay Bhaskar to give his conclusion.
Thank you very much, sir, Dr. Bala. That was a very great show, as I already told in the beginning. It's a very good learning experience for everyone. I hope this video, which is hosted in the YouTube, will be very useful for all the students and those who are practicing in the areas where there is a emergency and trauma care. Thank you very much, sir. Any comments, sir?
No, thank you. I enjoyed it. Maybe my aim should be visit Hyderabad one day and do a live presentation.
Definitely. Perfect. Most welcome, sir.
Yeah. Thank you.
So we'll end the session with your permission, sir. Thank you very much.
Thank you.